So the last kind of longest recording device is an implantable loop monitor. It can be used for up to 3 years without a battery change, maybe a little bit less if it's getting triggered a lot. It does require weekly downloads. You can do that via the telephone or by going to the cardiology office. It's actually an MRI compatible device, which I think earlier on there were questions about. It's a relatively low profile device where it's inserted subcutaneously kind of in the almost midline left chest. So if you're taking care of a patient, you can usually palpate the device under their chest. It's a 20-minute outpatient procedure with one incision. Patients go home the same day. And it's really fairly well received. Of course, it's more invasive because you are actually implanting something in a patient, and so there are some risks associated with that. For me, I think the MRI safety can sort of be a battle depending on how conservative your MRI safety committee for your hospital is. So according to the inserts and guidelines from the Medtronic device company, it's safe up to 1.5 Tesla 6 weeks after implantation, and that's just so that the leads are like not migrating in your chest or something. It's kind of like enmeshed and endothelialized by your skin and tissue. So we have been able to get these loop monitors, because these are patients are at risk for recurrent stroke, and then we end up having to repeat MRIs with these implanted. The MRI can delete the data, so we always have to call cardiology to download the information before and then kind of make sure that it's working again after the MRI is done. So why are we talking about this? From 48 hours of recording to 3 years of recording. While previous studies have shown that the longer you monitor a patient, the higher the yield for subclinical AFib exists. And that kind of intuitively makes sense, although other people I think may have thought like, oh, if you haven't gotten it by 2 weeks, you're probably never going to get it at all. And some of the newer evidence has really shown that not to be the case. So this kind of goes a little bit in chronological order as well as duration. It's set up in duration of monitoring, anywhere from 6 days to 6 months, which was what the Medtronic study primary outcome was. I'll talk about that later. But like I said, it can actually go up to 3 years. And here you can see that there's actually quite a range of yield for AFib using the device. And it kind of ranges anywhere from 5% to almost 25%. So quite a large variability there. And I think some of that may have to do with their inclusion criteria as well as how soon after the stroke that they start the monitoring. Here are the AA guidelines from 2014 about AFib. This was kind of a meta-analysis that showed what I showed previously in a pictorial format, that the yield and detection rate for AFib tends to go up with duration of monitoring. This goes up to 30 days. This is before the implantable loop device recording study had come out in 2014. But you can see here that it's quite a range, anywhere from almost 0, where Holter monitor is almost not going to show anything. So frankly, I would not bother with it because it's a very labor-intensive study, but the yield is quite low, and skip down to something a little bit longer lasting like cardiac patch or CardioNet monitoring. So the weighted average detection study in this meta-analysis was 10%, so quite high. Although I must say that in clinical practice, anecdotally, my yield certainly has been lower, and I think that's true for other clinicians. So this was the XioPatch study. It was retrospective data-based registry, where they basically took all comers with patients who got this XioPatch, and they chart abstracted where the indication was for stroke and TIA. There's a lot of flaws to that methodology, of course, but you can see here that the duration of therapy was 13 days, which means that it's a really well-tolerated kind of diagnostic test. Patients don't really call and complain about it like some of this other cutaneous topical studies. And in the real world, the detection rate for AFib was 5%. So kind of, I honestly think, aligned with my anecdotal experience. It's actually the largest data set known. It's over 1,000 patients. Of course, it's very limited because it wasn't a prospective study, so we did not have good clinical data on kind of the characteristics of the patient population or how thorough the stroke workup was. So one can imagine that if you don't have a clean kind of source of patients, that some of them actually had other causes of stroke, like cervical vessel disease or cancer, that the yield for this monitoring may be lower. So a more enriched patient population where they were really cleanly cryptogenic and usually older, if they're higher risk for AFib, would probably increase the yield. The Embrace trial looked at 30-day recording device. This was from Europe, so it's not the CardioNet that we're talking about, but they had another kind of prolonged cardiac monitoring device that lasted 30 days. And this is, I would say, a relatively enriched sample set where the age of the patient, by definition, is over 55, and they were enrolled within 6 months of stroke. And here, I want to point out that the detection rate is much higher for patients who are enrolled within 3 months of stroke than the patients who are enrolled 3 to 6 months. This is kind of the argument to me where, similar to the cardiac surgery or the CEA, the carotid endarterectomy studies, show that the earlier and sooner you do the diagnostics, the higher the yield is. So unfortunately, depending on where you're working, I may not be seeing the patient until 6 months after the stroke. I still go ahead and do the prolonged cardiac monitoring, but gosh, I wish the patient got this test, at discharge or 2 weeks after their stroke and not 6 months down the road when they're seeing me in clinic. The yield is certainly higher than in the control group, 16%. And again, I think it's partly because of the enriched patient population given the age and the soon enrollment after stroke. The Crystal AF study, I think, it's the main implantable loop recorder study. It specifically uses the Medtronic Reveal device. It enrolled 447 patients. It had people 40 and older, and yet at 12 months, it still had a 12% yield rate for paroxysmal AFib. They were enrolled quite soon after a stroke, within 90 days, and I think that kind of counteracts some of their younger age set because, as you can imagine, for younger patients, the yield is probably a little bit lower. I would like to point out that 2% of patients did have removal of hardware, and there are usually minor side effects or adverse events, including hematoma at the site of implantation, or more concerningly, if they've had infection at the site of implant, but generally is very well tolerated. And the other thing I'd like to point out is that this was a diagnostic study. It did not dictate change in management, but certainly anybody who did have a diagnosis of paroxysmal AFib generally moved towards a higher initiation of anticoagulation. And that kind of, and this I was just going to point out that over time, months since randomization, that this is 6 months, 12 months, and 3 years, that it never closes the gap, that over time, the implantable loop recorder will keep capturing patients that will have AFib. Some of it may be that the natural aging of this cohort of patients is that they're getting older and some of them may develop AFib. We are not really sure what it means if you got AFib detected 3 years after your stroke, whether or not it was AFib that caused your stroke, or maybe it was something completely unrelated. But I think certainly it suggests that maybe doing recording for 6 months is going to be higher yield than something that's 2 weeks for 3 months, or 30 days. So in summary, the guidelines from AEN are that you should consider outpatient cardiac rhythm studies for cryptogenic stroke, and that you may consider doing a prolonged period of recording of 1 week or longer instead of just the 24 hours to increase the yield of identification of patients. I mentioned this briefly because I think our clinical practice is that we're all doing this. However, sometimes insurers may lag behind on their indications or reimbursement. So I use guidelines and some of those other primary studies to help demonstrate or kind of help bolster support, when you write the pre-auth letters to say, oh, this is why we should be doing this for our patients, and it will potentially save money down the road because you're able to anticoagulate the right subset of patients and prevent recurrent strokes that will, certainly cost the insurance company and the system more money. So now what do we do? Oh, sorry. So this is kind of my recommendations for what to do for cryptogenic stroke. Think about the other clinical features, kind of use your memory ticklers to see if there's other things you need to think about, such as recent trauma, maybe it means portends a dissection, other family history, you have to consider other genetic hypercoagulable states, or other kind of other thromboembolic events suggesting either an acquired or genetic hypercoagulable state. And then for actual people that have cryptogenic stroke, I would order prolonged cardiac monitoring. And the sooner after the stroke, the better. The best would be at discharge. However, I would like to point out that all these cardiac monitoring has been approved only in the outpatient setting. So, for example, for some of you guys who work in acute rehab, you may not really see these in acute rehab because they're not approved for rehab settings. Therefore, what unfortunately is happening is that we would discharge a patient to rehab. They go there for 2 to 4 weeks. They get better. They get home. They show up in my clinic 3 months later. Then I order the cardiac patch. Or if there's some other system where I can arrange for them to get the cardiac monitoring after they're discharged for rehab, that's what we would do. But it's because of these kind of silly insurance barriers that we're not able to send them out with a CardioNet or a Zio patch in rehab, even though it's probably a very safe setting. I mean, they're getting therapy. It's really no different than being at home. They're getting exercise, bathing, etc. And what I'm personally doing with the implantable loop recorder, although I think there's a lot of variability there, partly related to reimbursement schemas, I currently am using a topical recording device, such as a Zio patch or CardioNet. And then for patients who are suspicious of AFib or other arrhythmias based on their topical recording device, I would refer to ILR. For example, if you have a 30-year-old patient who you probably think have some other atypical cause for stroke, like migraine or RCVS or something else, your yield is probably going to be low. So I would probably forego kind of exposing them to the additional risk of an implantable loop recording device. And certainly if it was a 60 or 65-year-old patient who is at higher risk for occult AFib, or if they're presenting for a second time a recurrent event, I would seek an ILR. Generally, here it's the interventional cardiologists that are doing it. Again, it's pretty easy to arrange because it's an outpatient low-risk procedure, so we haven't really had any pushback from that. So next, I like to talk a little bit about what to do when the patient does have paroxysmal AFib. The short answer is that everybody should get anticoagulated, while the long answer is we're using the CHA2DS2-VASc score. And the reason that everybody with a stroke should get anticoagulated is that here I like to point out that a prior stroke or TIA means you automatically get 2 points. And also, if you're over the age of 75, you automatically get 2 points. So when you start doing anticoagulation for everybody with a CHA2DS2-VASc of 2 or greater, that basically means everybody who's had a stroke or TIA. And that's because of their annual stroke risk goes up significantly as the points add up. So what can we use? I think everybody here is really familiar with warfarin. It's been the mainstay of cardioembolic secondary stroke prevention for a long time. And now there are kind of lots of new kids on the block to be used. There's 1 direct thrombin inhibitor and 3 factor Xa inhibitors. I personally have the most experience with these 3. This is arranged by chronology when they're approved by the FDA. So the dabigatran was approved in 2011, and doxaban's the latest, and it's approved in 2015. Here are all the trials that kind of enumerate the different kinds of patients there are. You can see that the Voraxaban group, the Xarelto group, actually had the sickest population, where the majority of patients had stroke or TIA. This other study, which I would think is also pertinent, is apixaban versus aspirin for patients who cannot tolerate warfarin, and it was also superior to aspirin there as well. So these were all non-inferiority studies, but as you can see in their kind of secondary outcomes, they have all basically been shown to be non-inferior or possibly even superior to warfarin. So I think the trend is that all of these drugs are more commonly used and offered to warfarin for patients who can afford it, basically. So when would you not anticoagulate? Certainly, if it's not aligned with the patient's goals of care, if they're hospice bound, if they have other thrombophilia or bleeding diathesis, if they have another primary intracranial hemorrhage risk, such as amyloid angiopathy, or if their Has blood score is high. And I'll briefly touch on that. The Has blood score is a clinical risk factor scale that we use to kind of estimate what their risk of bleeding from anticoagulation is. And generally, if you're 3 or higher, you're at high risk of bleeding. So you would really kind of think twice about it if your patient has a really high Has blood score, or a kind of you want to go back and weigh what their annual CHADS-VASc score is to decide which one is kind of like the lesser of two evils you're offering the patient, either bleeding or an ischemic stroke. And it's really, I would say, a shared decision-making conversation with the patient. And briefly, I want to mention, so all the NOACs are non-inferior. I'm basically using all of them basically based on patients' formulary from their insurance. All of them have relative risk reduction, 50 to 80%. So it's not uncommon for patients on an anticoagulant come in with another ischemic stroke. They may have not been taking it, but they may have been taking it religiously and still getting a stroke because none of these meds are perfect. And the last thing I want to briefly touch on is something called ESIS, which is a type of, I mentioned before, it's a type of cryptogenic stroke that looks embolic on imaging characteristics. It's not subcortical. It's larger, 1.5 centimeters or larger. There's no large vessel that is attributing the proximal source of the stroke, and there's no AFib detected by standard testing. So this is kind of an uncharted territory, and we don't know what to do with these patients. The current guidelines are to give them aspirin and Plavix. But there are 2 ongoing trials and a third on the way that looks at these new novel oral anticoagulants and see if they're potentially better at preventing stroke for this subset of patients versus aspirin or some other antiplatelet. That's the Respect ESIS and the Navigate ESIS trial. So you may see some patients in your clinic or in your encounters that are on a study drug, and that's what this is for. And I think the earliest data is going to come out in about 3 years. So we may potentially, the chart of kind of the therapeutic plan would be different in 3 years if any of these trials are positive that suggests that a novel oral anticoagulant is better for these kind of cryptogenic embolic looking strokes. So briefly, I want to say that right now we don't know whether or not subclinical AFib is worth treating. I would say that clinically, as clinicians, we're like, oh, this is an abnormality, we got to treat it. And I don't know if we're just treating ourselves. I mean, 30 seconds of AFib, we don't really know what that means. And the older studies, people thought at least 6 minutes of AFib was clinically relevant. But in practice, we're treating these patients. And I'm not sure if in the future these studies would get funded. In summary, we talked about how to evaluate a cryptogenic stroke. So you do structural heart imaging, vessel imaging, cardiac monitoring. Definitely do prolonged cardiac monitoring for your cryptogenic stroke patients. And for patients that you do diagnose with paroxysmal AFib, all the NOACs, the novel oral anticoagulants, are now non-inferior. I would say that in the marketplace here, that apixaban is kind of leading the forefront there. I think Xarelto is second behind. They both have their pros and cons, and it's kind of dealer's choice, I would say, and insurance formulary choice. And warfarin is probably still best for dialysis patients. Okay, do you guys have any questions?